It's a hard act to follow Professor Babchima. His belief, his eloquence, and verbosity is impossible to match. However, distinguished chief guest, Mr. President, Secretary, Chairman, Scientific Committee, ladies and gentlemen, it's indeed a privilege to address you at the inaugural session of 15th International Biennial ChessCon, commemorating the remarkable 30 years journey of Pakistan Chess Society. Reflecting on its inception, the first biennial conference on 23rd March 1994 in Peshawar served as a pivotal moment, uniting pulmonologists and thoracic surgeons nationwide. Today, as we gather to discuss challenges in postgraduate medical education and the challenges of postgraduate medical educations, let's draw some inspiration from the society's rich history and the collective dedication towards the promoting chess medicine in Pakistan. During my literature review for this talk, I stumbled upon an impelling editorial in JAMA from 1956 discussing the significant challenges in postgraduate medical education. This insightful piece offers timeless wisdom that remains relevant even today. Physicians have long acknowledged the need for lifelong learning for optimal care. The rapid expansion of medical knowledge and medical literature posed a challenge, making it very difficult for the physician to keep themselves updated through their individual efforts alone. Due to active research in that era, new information was pouring in, but a major challenge 70 years ago was effectively communicating findings of research to the physician for the benefit of medical care. At the time of famous Flexner report in 1910, the postgraduate education was entirely involved with the repair of grossly deficient undergraduate education rather than communicating to the physician the discoveries of the research. And that repair and refresher function of the CPD also started to fade as undergraduate and postgraduate medical education developed. Lack of well-designed postgraduate programs was also considered to be one of the major current and future challenges way back in 1956. So ladies and gentlemen, just summarizing the challenges of the past was expansion of knowledge, difficulty in keeping up to date, problems in translating research into practice, unstructured CPD system, and poor quality of training programs were the major challenges way back 70 years ago. Now, let's look at the current problems in postgraduate education after understanding challenges from the past. These challenges are so huge, which is making it difficult for teachers and students to handle. We could have dedicated the whole conference to this topic, but we would have not finished. So in this 20 minutes, what I'm trying to do is, whatever I feel is the challenge today in education, I'm going to elaborate on. A big issue in medical education is the gap between knowing and doing, between competent and performing well. It's not just marking the box, but it is truly understanding and applying the knowledge with right skill and caring attitude. Realists may argue that this competence and performance gap is a manifestation of pressure of work. In my humble opinion, poor quality clinical learning environment is the major problem in postgraduate education today. Postgraduate education usually occur in clinical settings such as hospitals, where healthcare professionals serve dual roles of providing patient care as well as training. Trainees progress through increasing level of responsibility on a sort of apprenticeship model. High quality clinical learning environment is vital for postgraduate education. It refers to social, cultural, and material context where residents learn while working. The high quality clinical learning environment should afford the residents with supervised patient care participation, coaching, assessment, feedback, teamwork, peer collaboration, and observable models of practice, fostering practical knowledge, skill, attitude, and development of professional identity. Just consider for a moment, most of you have gone through this. Does our program have all these? No, I think there are a lot of shortcomings. I would like to share a superb study by Kilty et al. From Republic of Ireland. The objective of this study was to identify important barriers and facilitators of learning in clinical learning environments and indicate priority areas for improvement. In this study, the stakeholders identified 10 distinct domains within clinical learning environment. Domains which were rated the most important were those related to residents' connection to and engagement with more senior doctors. I'll repeat it again. The domain rated most important were those which related to residents' connection to and engagement with more senior doctors. And the domains which were most difficult to improve were the top two, which is organization and condition of work and time to learn with senior doctors. The major barriers to learning in that study was busy clinical areas hindering resident learning, time constraints impacting mentorship opportunities with senior doctors, lack of support from hospital management, low staff morale due to overwork, and poor communication between supervisors for training continuity. This study was from Ireland, but I'm sure these barriers are very much there in our setting as well. If we do a study like this in our setting, it will have all these barriers, but the only difference would be that the list might be very long, which I don't want to go into detail in this short time. So we can address these shortcomings in clinical learning environment by collaboration, effective collaboration between hospital managers and academic leaders, by faculty development programs, by access to resources, easy access to learning resources, by making the supervision more intense, and by developing feedback mechanism for the students, which will go a long way in improving the clinical learning environment in our country. One of the two most important aspects or challenges in our postgraduate medical education, or for that matter, any discipline in our country, is the dearth of professionalism. After a wonderful talk on professionalism, the best I've ever listened to was from my friend Babar Chima. So I don't have much to say about this, but I will try to relate it to postgraduate medical education alone. I'm sure you know Dr. Gregory House. Any one of you who don't know him should go to Netflix and watch this TV drama. On one hand, you will see a genius of a doctor, but on the other hand, a person who lacks professionalism and respect for ethics. Very interesting. You watch it and you'll know what professionalism is. You learn a lot of medicine though. Lack of professionalism can lead to issues. I'm now talking of professionalism in the real world. Babar Chima was a bit too high for our understandings of certain areas. In practical terms, lack of professionalism leads to issues such as decreased quality of patient care, strained doctor-patient relationship, erosion of trust within medical community, and it is important to address these issues for maintaining high standards of patient care, preserving trust, and fostering a positive and collaborative medical community. The proficiencies of professionalism are best taught through direct clinical care. So the trainees follow their supervisor, their teachers. The trainer is a role model, mentor. So hence, very important for a trainer and a teacher to remain within the ambit of high level of professionalism. If you stray, all your students are going to follow what you are up to. It is very important that in postgraduate medical education, we do not lose sight of training the soft and non-technical skills such as communication, empathy, leadership, teamwork, critical thinking, situational awareness, emotional intelligence, a long list, but it's a part of resident life in a performance-driven landscape. The current better informed community is now aware about their right for healthcare services based on accountability and transparency and demand for adherence to standards of professionalism. Gone are the days when they would say, "Bas, Allah ko jo manzoor tha, wo ho gaya. Thank you for what you have done." And it is due to this issue that we unfortunately come across incidences like this not too often in our country. We can address professionalism issues by robust measures like inculcating soft skills into the main curriculum, which will go a long way in helping the postgraduate medical students to have professionalism in them. Also, by accountability mechanisms and intense training, we can work towards the culture of professionalism in our institution, which is so much of benefit for the healthcare professionals and the patients. Establishing A safe learning environment is fundamental to adult learning as well. Without it, the essential disclosure and sharing required for learning team to engage in a meaningful dialogue in order to improve practice is unlikely to happen. Adult learners value respect, yet a culture of teaching by bullying still persists in our institutions. Continuing professional development has its own inherent issues of time constraints and cost. But one of the major issues in CPD is the lack of clarity in the reward system in CME and CPD. There is a need for standardizing the exchange rate or the reward system for educational activities across all accrediting bodies. We all know that reward exists for undergraduate and postgraduate qualification, but it is CPD which often goes unrewarded. To my knowledge, the MTI is in KP have actually introduced and implemented reward system for promotion and for your evaluation. PMDC developed CPD standards, but they're still not implemented. We need to implement them as soon as we can. The other issue is that of teamwork. At the undergraduate or professional training level, doctors, nurses, allied healthcare professionals, and managers often receive education separately, focusing on their respective disciplines. However, in real-world healthcare settings, effective collaboration within multidisciplinary team is essential for optimal patient care and outcome. In order to address this issue, the educational institution should implement interprofessional education initiatives in which the students from various disciplines are brought together where they collaborate and learn. So by fostering effective teamwork and mutual respect, the interprofessional education can improve the patient care and outcome through multidisciplinary collaboration. Now I'll spend a few minutes on specific problems of postgraduate education in our country. This slide, of course, you all know that limited resources, lack of funding, shortage of faculty and facilities, quality assurance issues, and brain drain, loss of talent are and have been the issues for decades. The postgraduate production in Pakistan is mainly by two institutions, CPSP, College of Physicians and Surgeons in Pakistan, and the universities, ratio of 80% and 20%. There is a need that both these institution policies should be aligned to each other, and postgraduate medical education should also be aligned to the policies of the government. As an example, government of Pakistan wants to introduce universal health care through family practice model where around 60,000 GPs are required, but there's hardly any effort from CPSP or the universities to produce family physicians. Postgraduate production has exponentially increased in the last 2 decades. CPSP boasts to have produced 50,000 postgraduates, mainly FCPS but unfortunately, they are not exactly according to the need of the country. So assessing the need of specialist need is also vital. For example, predicting the number of anesthetists which are required by year 2050, or intensivists, or pediatrician, etc. Increase in postgraduate production has also posed serious quality assurance challenges, and you know better than me. So there is a need for robust quality assurance programs which should extend beyond mere accreditation. At the moment, CPSP concentrates more on just accreditation and then leaving everything to the supervisor or to that institution. And we know there is explosion of increasing number of trainees, increasing number of institutions which are accredited and just accredited and then left alone, which is causing serious quality assurance issues. CPSP is regularly updating its curriculum, and these days it is following competency-based curriculum, which is not the case with universities. So our universities also need to upgrade their curricula. Another challenge is the conflict of interest between the universities and CPSP. Most of our faculty actually run both these programs. So hence, increased number of trainees, dilution of quality, and the most and the best example is the dilemma of the leadership, where the president of the CPSP is on one hand the president of CPSP, and on the other hand he is the vice chancellor of a university, and still both these institutions are poles apart. So we would hope that our president of CPSP, through his efforts, will bring the policies of these two institutions together and bring the quality of these two institutions at the same level. It is important that we enhance our simulation labs and skill centers, which is crucial as they play a significant role in refining resident skills. Excuse me. Additionally, integrating soft skills such as leadership, communication, and empathy and ethics into curricula will enrich and ensuring a more comprehensive and holistic learning experience. Last but not the least of the issues, inadequate infrastructure, financial constraints, limited training, and regulatory challenges hinder the integration of digital technologies in postgraduate education in Pakistan, necessitating collaborative efforts for sustainable solutions. How to address these challenges? In my opinion, besides the solution that I mentioned for individual challenge, one of them is to establish functional departments of medical education in the hospitals. Through their expertise, they can easily manage the knowledge explosion with guidance and study guides. Being experts in curriculum, they can shape the outcome-based and competency-based curriculum. They can address the hidden curriculum, emphasizing leadership, communication, and management skill, and their input in workplace assessment can prioritize formative feedback, which is so important for the quality of training, and their input in the faculty development and CPD initiatives, including role modeling and mentoring, will ensure ongoing professional growth. So conclusion, ladies and gentlemen, residents face challenges in underfunded, understaffed, and overcrowded clinical settings. Patient safety relies on fostering supportive clinical learning environment. Trainees need time to engage and connect with senior doctors for mentorship during patient care, and they need recognition as valuable contributors. Collaboration between academic, medicine, and health service manager is vital for ensuring safety and excellence in patient care and learning, and continuous improvement in postgraduate education is vital for evolving medical practice. Thank you.